Hi everyone, my name is Meagan Rivers. I am a clinical coordinator at 728 State Street. I am a licensed mental health counselor, a national certified counselor, and a certified clinical trauma professional. I have spent many hours studying and training and researching how trauma affects the body, the mind, how it affects those who struggle with addiction. I am excited to be able to share some information with you that I learned at the most recent trauma conference in Boston. I was lucky enough to get to go in person this year. I've attended virtually before, but being there in person was definitely a whole different experience. So I hope that you enjoy this training and are able to gain some knowledge of trauma and how to manage it. Okay, so step one, what is trauma? I'm sure there's a Webster's dictionary definition somewhere, but for the purposes of this training, just distressing events, that is what trauma is. It's any distressing event or experience. It is something that we don't get to say what is traumatizing to another person. Something that we may find, no big deal or doesn't affect us at all, may in fact cause a great deal of distress to someone else. The trauma does affect everything. It affects the way that we react to the world around us. It affects the way that we react, when somebody makes a loud noise, when somebody walks down the stairs, when somebody's behind us, if we can't see what's going on. It becomes something that a lot of people don't even recognize as affecting them. It just becomes the norm from their day-to-day life. And it may not be helpful to them to continue living that way. One of the biggest things that I think we see here and what we do is, obviously we see trauma that's experienced throughout the lifespan, but the majority of our people have experienced some type of childhood trauma. And childhood trauma can affect the development of the brain. It affects how the prefrontal cortex is developed, how it connects to other parts of the brain that give signals of the fight or flight. Is there danger here? Is there not? So somebody who has experienced early childhood trauma, sometimes they're activated by things that they don't even realize are happening. They're very agitated in a room full of people. They don't know why. They're just uncomfortable. Or, somebody makes a loud noise or slams the door and they jump. And sometimes we'll all do that if we're not paying attention. Loud noises can scare us, but an increased startle response is something that happens with trauma. There is, when there's that disconnect between the prefrontal cortex and the other parts of the brain, it causes struggles with regulating emotions, with regulating, reactions to things, with regulating impulses. And that can show up in many different ways. And I'm sure we've all worked with people who struggle with the impulse control. Um, that's, a piece of addiction is it's hard to say no to the substances that they're using for many reasons, but this can play into it as well. Okay, so I guess the next step is, how do we create a safe space for our participants? I included a quote that I really like on this slide, and I'll just read it out loud. It says, "Shame dies when stories are told in safe spaces." And this is something that I have seen so many times. I have had people open up and just share things that are sometimes horrific, that are sometimes they're very ashamed of, or they're very scared of telling somebody, and watching a weight lift off of people as they're allowed to share their experience without judgment, without feeling like I'm going to get in trouble or this person's not going to like me. That makes such a difference for people. The other thing that I personally do is I don't say this out loud, but it's kind of implied in the actions that I take with the participant in a session. I will tell them that, I'm here to help them. The space that we're in is for them, to help them. I'm here to help them. But I have allowed people to get up and go smoke a cigarette in the middle of session. Some people might be like, why would you ever do that? But sometimes somebody's just talking about something that's really, really stressful and they need to get up and take a minute. I've had people pacing back and forth in my office. I have people who will fidget with things all the time, and I allow that because it can give people a sense of control. And I remember when I was still in my internship, I asked one of my professors, like, is it okay that I let the person go on a break in the middle of session? And she looked at me and said, you probably gave a person who has never felt like they were in control the feeling that they were in control of what was going on in their life. And that makes a huge difference in healing and learning to speak up for themselves and advocate for themselves. This slide shows some of the symptoms that we may see or the behaviors that we may see in people who have unhealed trauma. There are many different ways that it can look, and it can be difficult to figure out, is the person, are they angry? Are they paranoid? Are they depressed? What's going on with them? And sometimes if we stop at, okay, they're depressed, and we don't look any deeper, it begs the question of, are we actually getting to the root of what's going on, or are we just giving somebody a name for what they're experiencing and leaving it be? And that's not really what we want to do. We see this in almost every participant we have. All of our participants have experienced trauma. All of them. Whether they had the perfect childhood or not, just the life that they lived when they were using is traumatic. It just is. So some of them are more severely traumatized than others. So we are going to see this. This is going to happen. And just a note, since my face is in front of the one on the bottom, it says struggles regulating strong or uncomfortable emotions. So sometimes it can be hard for us when we're dealing with, 10, 15, 20 people to manage all of these different types of things that are coming up for people. Something that I think helps me in understanding how our participants are reacting, why they're reacting a certain way, is to look at it as some of the behaviors that we see as problematic behaviors are the way that they adapted in order to survive. To us, it looks like somebody acting out or acting childish or, not wanting to do what they want. But for the person, it may be the only way that they have ever learned to actually survive their life or to make it through severely traumatizing things or, a lot of emotional pain or anything like that. Something else that I wanted to note is kind of knowing anniversaries. I know a lot of us, we kind of watch to be like, okay, when's your soberversary? Like, because we know sometimes people can struggle when it comes around to a year or different things. But it's important for us to also know when there are other anniversaries coming around, like deaths of family members, overdoses that they may have had, ending of relationships, anything like that. Those are important for us to know because there are times where people will just feel off. Something will just be going on, something will be wrong, and we won't really know what, but we just know something is wrong. Sometimes with them, sometimes with us. Put this on human, not just participant versus clinician, but like human. We might notice that somebody's off, and if you ask any of my participants, they'll tell you, I will ask when they're like, I just don't feel right. I will look at them and say, are there any anniversaries at this time of year? 85 to 90% of the time there is, and it comes up and we're able to process it and I'm able to help people understand why they're feeling a certain way. The best example I always give is, I've given two examples. One is surrounding the anniversary of a fire that happened across the street from my house, and another is just the example of 9/11. Both of those things around those times, I'll start to just feel a little off. And even if I don't recognize what time of year it is because I'm self-aware, I'll notice that I don't feel right. And then I'll look at the calendar and I'll be like, oh, this is what's going on. So I'm just a little more gentle with myself. I give myself a little bit of extra self-care at that point. And that's something we can encourage our participants to do as well. The next thing I want to talk about, briefly, I guess, since I know I've had this slide for the last 3 or 4 years since I've been doing this training, but I wanted to talk about PTSD, which we hear a lot about, CPTSD, and moral injury. Um, CPTSD is also sometimes referred to as developmental trauma disorder, or DTD. They're working to get that in the DSM. Um, Moral injury is a newer diagnosis. They're still kind of working on that. That's one that they've recognized, in veterans coming back from war, same as PTSD was originally discovered because of Vietnam veterans and things they were experiencing coming back from the war. Um, these things all affect our participants. Um, Sometimes there's multiple things. Sometimes there's all three affecting the people. Um, I think the most important piece that I want to point out here, well, a couple of things. You can see there's some overlaps in the things that can cause each one of these disorders, I guess you can call them. The one thing about moral injury that is very different from the PTSD or the CPTSD is moral injury can be something that you've witnessed, that you learned about somebody doing, or that you yourself have perpetrated. So this can be if we have people who, if they're pushers and someone overdosed when they injected them, or, we have people who are combat veterans who have had to kill people, or we have people who have, lived through gang violence. There can be things that they themselves have done that they don't know how to cope with and they don't know how to deal with. And it feels like a piece of them has been left somewhere else or is no longer there. And then the other thing that I see PTSD is it's a complex one. And that one is one that I always preface by saying to people, and I say this not just in this context, but, talking about something that happened when you were younger does not mean your parents were bad parents. Um, they may have given you everything that they could, and that may not have been enough. That's just the reality. Um, but I always, in order to help decrease the amount of defensiveness that may come up in people, I always like to reiterate that, especially with the complex post-traumatic stress disorder diagnosis, which, again, it's not in the DSM, but it is an ICD recognized one, and it is being worked on to get it into the DSM. There is a handout that should be attached to the email that this was sent on, and it kind of shows how the three things overlap, and it's a good image kind of to help you see what these things are. Okay, so as you can see, I left my little note on here about add more about what a flashback looks like. So I'm just going to go right into talking about that. The slide just kind of shows CPTSD, what that can look like, some of the symptoms that can happen from that. So one of them on there says emotional flashbacks. What I'm going to talk about is the three different kinds of flashbacks. There's visual flashbacks, somatic flashbacks, and emotional flashbacks. Somatic flashbacks are when people actually feel the physical sensation of whatever was going on during the trauma. So if somebody was being abused, they actually feel like they're being hit. Or someone was in a car accident, they feel the physical symptoms or not symptoms, the physical pain that they felt during the car crash. Visual flashbacks are when somebody is visually seeing whatever was going on during that trauma and they're transported back to that. So it's, somebody's sitting in the room with you, but they're visually seeing when they were in prison or when they were in Iraq or Afghanistan or wherever they were, whatever was going on. And in that moment, the person is not, their body is physically there, but they don't feel like they are. So it's important to know in those moments if somebody is stuck in any kind of flashback. I'll get to the emotional flashback in a moment. But with the visual flashbacks, it's important to, if you can, help the person try and ground themselves back into the room that you're in. It can be asking them, to do the 5, 4, 3, 2, 1, the things you like smell, taste, hear, see, that grounding technique, which we'll talk about grounding more in a later slide. Um, the other thing to be aware of is when someone is in the middle of a visual flashback, they're not seeing you in that moment necessarily. You don't want to make loud noises to try and get the person's attention. You don't want to walk up behind the person. Absolutely do not walk up behind a person. You don't want to come at them. You want to, speak in as gentle a voice as you can. If it's not something you're comfortable dealing with, call somebody who can, have a calm demeanor. Somebody who has a rapport with the person would be a good person to call if something happens. One of the questions that I will ask people after we've been, excuse me, processing some heavy stuff is, where are you mentally right now? And sometimes I get the answer of in the room, meaning in my office, but a lot of times I get the answer of I'm in blah, 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 which is wherever the trauma took place. And I ask that a lot to try and make sure that I don't let somebody walk out of the room who is in the middle of experiencing something that could cause a lot of detriment to others and themselves if they leave the room. Sometimes what I end up doing is just trying to redirect their thought process and ask them about something that's completely off topic or something that's completely different. Like, do you watch any good TV shows? Like, what's your favorite song? How, what are you doing this weekend? Just to try and get their mind to come back into the now. Those things can look different and it really depends on the person, but I think my biggest thing to stress to you is do not make loud noises to get someone's attention and do not walk up behind them. So the third type of flashback is an emotional flashback. And this is one that we hear about the visual flashbacks quite frequently. But the emotional flashbacks can be much harder to determine that it's going on. They can last for a few moments. They can last for a few days. Sometimes it feels like the reaction that somebody has to something is 10 times bigger than what the situation calls for. And that can be a sign that somebody is experiencing an emotional flashback. I recently had someone where he was going through some things and I asked him, and I'll ask this of people, like, how old did that emotional reaction feel? And he was able to identify it was much younger than his current age because it was old emotions that were coming out. And that's the hard part about an emotional flashback, because sometimes you'll be upset about something, and rightfully so. The reaction, but that situation may have triggered old reactions. It may have triggered old responses, and it can be more difficult to come out of. But the first step is acknowledging that it's happening and then being able to move past that. Sometimes when you'll see and you'll be like, this person's acting like a 5-year-old, or throwing a temper tantrum like they were a teenager. And sometimes that is a sign that they are having an emotional flashback, whereas they are emotionally responding as if they were 5, as if they were 12, as if they were 20. Like, they are responding based on something that's not actually currently happening. And that can be very difficult to deal with, but it is possible to deal with it. And it's very difficult, especially when people are living in the halfway houses, to try and navigate, somebody who's having a flashback, somebody who is dealing with all kinds of emotional things. Like, it's very, very difficult to navigate that when you've got 15, 20 people in a house in this enclosed space, and out of 15, 13 of them are experiencing some sort of traumatic response. So reach your coworkers for support. That's why we have supervision. That's why we have each other, so that we can talk, because sometimes we just need to talk something out so that we don't carry it with us home. And that's critical for us to be able to continually do this job. Okay, the next thing I have is moral injury. I'm not going to spend too much time on this slide because I kind of talked about it in the earlier slide with the PTSD, CPTSD, and moral injury. I think the thing that I want to reiterate again is moral injury can be caused by doing, witnessing, or failing to prevent something that goes against deeply held moral beliefs. It's something that, as I said before, is really starting to be studied more in veterans and active military members. It's something that if you Google it, a lot of the papers and everything on it right now currently do involve the military. And a lot that makes sense. Um, that's a group of people that the government has control. Control is not the right word. That a group of people that the government oversees, who they can recognize when these things are happening. So, I mean, it can be, like I said in the earlier slide, when they're witnessing horrific things, when when they've committed crimes that they may have thought they would never do, and they've crossed lines that they thought they would never cross, letting go of those things and trying to work past that and keep moving forward can be extremely challenging. And sometimes all we can do is just continually encourage them, like, things are going to get better, like, you did the best you could in the situation you were in. Or sometimes it's, talking to them about the way to move forward is to how do you make sure that never happens again, or you never do that again if it's something that they did. And, kind of acknowledging that if there was somebody in their life who they witnessed do this, it doesn't mean that, they're a bad person for choosing to hang around with this person, or that they need to seek revenge on this person, or it's their job to, make sure that this person doesn't do this ever again. Like, we don't need vigilantes. That's not the point of it. But yeah, so moral injury, hopefully more studies will continue to come, and this will be more and more acknowledged and known about. So the next thing I wanted to talk about was overdose. This is something that, working in this field, we all hear about on a regular basis. We have lost participants to overdoses. We try and help our participants cope with losing loved ones. Even some of our, fellow employees have lost family members to overdoses. So it's something that we all deal with on a day-to-day basis, and it can affect us. It can affect our participants. It can affect how we do the work. It can affect all of it. So there's two things I wanted to do with this slide. The first is, there's the facts up there, and it says, there was a 3% decrease during 2023 from the preliminary reports, which is amazing. That's wonderful. 3% decrease, better than it going up. My question is, why is it lower? I think this shows the effort that has been put into help educate everybody on what an overdose is, how to reverse an overdose, the fact that naltrexone is much more readily available. More people understand the importance of having it available to them. I don't want to take away from the fact that the overdose is decreased. I just do want to note that this is deaths from an overdose. This does not include people who were revived or who their overdose was reversed by Narcan. So there's the potential that really the overdose rate has gone up, but the amount of deaths has gone down. There's not really a way to know that. because overdoses are not reported all the time. The second thing that I wanted to talk about is how difficult it can be when somebody either survives an overdose themselves or feels that they are responsible for someone else overdosing, or feels that they should have been able to prevent somebody from overdosing, they should have done more. That all connects. And there can be so much guilt. If you wake up and the person next to you is dead and you're fine, like, you feel so much guilt about that. They can be hard to stop using and to keep living with yourself and the things that have happened. In the in-person training, I'm going to have just kind of a discussion about, overdose and how it affects us and how it affects our participants and how we can help them and help each other. If you ever feel like you need to talk, you need to discuss something, you can always come find me. I don't remember my office number, but I'm at 728. I'm sure someone can direct you. The other thing that I wanted to talk about with this slide is I kind of wanted to talk about how deeply it really can affect people when someone overdoses. I think a lot of times I've heard participants where I'm like, oh, how are you doing with losing this person to an overdose, blah, blah, blah. They just kind of, they're like, it happens. And it's just something that they get so desensitized to. But it can be very, very difficult for them to deal with. So some of you may have seen last year the image that's in the middle. That's just the partial face. This was an image that one of my participants drew probably a couple months into treatment with me. I had asked them to draw, what does addiction look like to you? And they drew this image. And then a couple of weeks before last year's training, me and this person were able to identify that this was actually a picture of somebody who they had lost to an overdose. And I want to read what I actually wrote out. So this was actually somebody who that they had lost over a decade before. And the participant definitely felt a sense of responsibility for her loss, saying things like, I should have been with her, I should have answered the phone. They held the belief and self-blame and hatred for a long time. They tried to follow this person. They tried to overdose. It didn't work. They survived, obviously, because they're working with me. This was an event, as well as the beliefs that came from it, that pushed their addiction to another level and precipitated a long and dangerous downward spiral. They were unable to even hold an image of this person in their head without feeling overwhelmed and dissociating. And for me, I truly do believe that without identifying, working through this whole process, their recovery would not have been as successful as it is. So the second image, where it's the full face, is the person who they lost, and it was from about 7 months after last year's training. So it took about a year and a half for them to go from not even being able to say this person's name to being able to show me an image that they drew of their face and tell me the memory that it went with. And that healing process, that grieving, being able to allow them to hold onto this person and release their pain, holding space for them to actually share it, even though it was something that happened a long time ago. It was as if it happened yesterday. All of that really, really gave this person an opportunity to truly work through the pain that kept them stuck in their addiction. So this slide, this is something that I did get to learn about specifically at the trauma conference this year. And it was one of my favorite talks that I listened to. And it's something that I realized that I use in my day-to-day life with our participants, but I didn't realize that. But so, neglect trauma. what even does that mean? It's can be a little bit difficult because when we think of neglect, we think of, oh, somebody who was left and they weren't fed and their parents didn't take care of them. Those are severe cases. There's other ways that neglect can affect people. Something that the presenter said specifically was neglect at its root is what didn't happen. So when somebody says, oh yeah, I had a great childhood, I had everything I wanted, I had, tons of stuff and all this, if I wanted something, I could do it. I didn't have to ask permission. I just did whatever I wanted. All of those things, that in a way is a form of neglect, because a child doesn't need somebody to give them all of these fancy things. They don't need them to give them material things. They need them to give emotional support. And not getting that emotional support can harm somebody. It makes them not trust people. It makes them very resistant to treatment. They don't want to ever have to ask somebody for help. And that really stems from when parents aren't giving children what they need. The child is learning that they can't trust anybody, that if they want something done, they have to do it themselves or it's not going to get done. Because on a biological level, the parent is the person who is supposed to be taking care of them. The parent is the person who is supposed to be caring for them. And when the parent is ignoring their needs, they learn that what they need and what they feel does not matter. I'm sure that sounds really familiar to a lot of you with things that we have had to deal with participants, even among ourselves. The things that I want to note on here is the connection between that attachment not forming correctly when someone is a child and symptoms of ADHD. They're directly correlated, because when somebody doesn't have that solid base to go off of, everything feels chaotic, and so they're chaotic. There can be physical symptoms from this kind of thing: fibromyalgia, autoimmune diseases, migraines. The body is basically trying to cope with something that it doesn't know how to deal with. So when we're working with people who have struggled with like some severe neglect in their childhood, there's a good chance that they are going to push back at everything you say. They're going to try and tell you that you're wrong. They're going to try and prove that they know more than you. They can be very difficult to work with. And if you come from a place of compassion and understanding and you start to recognize where this is coming from, it can help you as the person understand why the participant is acting this way. It can also help you be able to educate them on how much certain things that they didn't get when they were younger, or certain neglectful things that happened to them, are affecting them currently. And it is really important, because a lot of times we look at the mental health component, but there can be a physical component to a lot of things as well. And sometimes it's when there's physically something going on and we don't know why it's happening or what's going on, is sometimes people can feel like, well, I'm just making this up. They get dismissed by doctors. They get stuck in this continuous cycle of feeling like what they're feeling does not matter, or they're making it up in their head, or it's not true. And if I tell somebody about it or I try and talk to somebody, they're going to dismiss me and tell me it's not real. And it's this perpetual cycle that we can help people break by actually listening and hearing them. So I want to shift the focus to us as providers in ways that we can be affected by the trauma that we hear from our participants. This is called indirect trauma. You'll see there's 4 different things listed here: vicarious trauma, secondary traumatic stress, compassion fatigue, and burnout. We've all heard of burnout. We always talk about, self-care, 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 like make sure you do what you need so that you don't burn out. Absolutely 100% true. We have to take care of ourselves. There are, I listed symptoms under each of these. You can pause and look at that if you want. There is a handout that goes with this that kind of talks about what each one of these things feels like and how to recognize when it's happening and what you can do to kind of move forward with it. So again, that should be attached in here. So go ahead, look at that, and reflect on it if you need. So grounding techniques. I put this after the slide about how we can be affected by our participants, because I think grounding is something that we need to teach not only our participants, but we need to practice as well. It can be, I listed a couple of different ones here. It can be counting. So for some people, like counting from 1 to 100 is calming. For some people, it's reading a book or having, a certain scented candles, like Victoria and her spray that she has in her office. Or, sometimes people have certain music that they listen to, or they go for a walk, or some deep breathing, which is like, just stopping and just taking like a deep breath in and then breathing out and allowing yourself to kind of just have a moment to sit. Sometimes we have to practice that with our participants in session to help them learn how to do it, that it's okay to do it. The 5, 4, 3, 2, 1 is, it's, you ask them, tell me 5 things you can see, 4 things you can touch, 3 things you can hear, 2 things you can smell, and 1 thing you can taste. That is something that can help people. It focuses them directly on the room that they are currently in, because the base of what grounding is helping pull somebody back into the room that they're in, so they're not in that state of anxiety or the flashbacks. Even this can work to help pull people out of flashbacks. Whenever I am doing an assessment and I'm completing the modified mini, if somebody tells me that they do have trauma, that they've experienced that they're struggling with flashbacks, or they're struggling with, nightmares or any of those things, I always, always, always talk to them about grounding techniques. Some of them have certain things that they try that work for them. Some of them have things that they've heard of, but they've never really tried. It can be difficult to get people to do things because sometimes they feel weird about it. But if we practice with them, it can help them feel more comfortable. The other one that I've done a couple times is like telling somebody, tell me 5 red things you see in my office. Sometimes it's a variation, but it's easier for people because they're not trying to like find 5 specific things. If they're too stressed out, sometimes they can't. So it's like, just tell me 5 red things, and then have them list another color if they need to. I used this with somebody who was specifically in the middle of a flashback, and they were like, the first 2 things I couldn't even like really concentrate, and then by the time they got to the 5th thing, they were okay. Like they were back in the room, they were calmed down. I think it's important for us to also remember that being calm helps the participant be calm. There's that co-regulation thing that happens where it's like, if I'm agitated, the other person's going to be agitated. But if I'm calm and I'm, speaking in an even tone, and I'm just, keeping my cool, it can help bring somebody down. It can help decrease the escalation, because all they're feeling from you is that calm groundingness. Now, is it easy to do? No. Does it take a lot of practice? Yes. Are there times where you just can't feel calm in a situation? Absolutely. We're human. I think some of it is external, like what they see on the outside. They don't see us reacting to the things. But again, we are human, and sometimes they do see us react. And that's not a horrible thing. We never want to react in anger or anything like that to our participants. We never want to lash out at them or be cruel. That's not what we're here to do. If you feel like something like that coming up, excuse yourself from the room, because all you're going to do is damage the therapeutic rapport that you have with the person, if you even have one. But keeping yourself calm, practicing these things for yourself, so that if you've got back-to-back sessions, give yourself 3 minutes, go in the bathroom and take some deep breaths. Or, eat a sour piece of candy. Megan's got warheads in her office, like something to bring you back down. Resilience. This is something that I truly, truly believe that we have the privilege, and I do mean privilege, to meet some of the most resilient people in the world with the work that we do. Continually getting back up when they have fallen down, admitting to their mistakes, taking responsibility, repeating cycles is not an easy thing to live with. Having them acknowledge, what's happening, work through that, and continue to stand back up and keep moving forward is an incredible thing to witness. But we also see it among ourselves because we have really rough days where we're like, I don't know if I can do this anymore. And then something happens and we realize, yeah, we can. I have a saying that I say that is, what one takes, another gives. So when one participant is really struggling and something is going on, a lot of times something happens that, instead of draining the energy from me, it feeds the energy. And that's the beauty of what we do. There are days where it is so hard, and there are days where it is absolutely beautiful. So finding that balance helps us to be resilient. And it helps us show that resilience to our participants, and our participants show that to us every day. This is the final slide. This is the 6 guiding principles to a trauma-informed approach: safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, culture, historical, and gender issues. I think we do a fairly good job of being aware of all these things, of being inclusive of everybody who comes through the door, of being non-judgmental. I think this is why this agency is amazing, is because we do have the opportunity to see people from all walks of life, and we are not judgmental. Like, somebody can come in the door and they can feel safe walking in the door. If you have any questions, thoughts, comments, you can send me an email, or you can call me at work, but I'll probably be in a session and ignore you because I don't answer my phone during sessions. So thank you for watching this presentation. I hope it all flows together. Obviously, as you can tell by my hair being down, I took a break in the middle. So thank you and enjoy your day.